we will hop right into this. I think I've got the first speaking engagement, so AJ, let me know if anything pops up on the screen. We tried to divide this in a way that made sense for someone watching it. You didn't have three guys talking about very similar stuff that overlapped, so we tried to put this together so it came out as a whole. My job in this is to sort of set the stage. We'll talk about some of the basics of hip replacement, what you would be getting into if you're considering it, okay? And then we'll go into some of the specifics of the newer technologies that are out there that might be right for you. We are not the only members of the hip surgery team. I just want to take a second to acknowledge our chief, who is Dr. James Keeney. And we also have number 3 on the list, Dr. Brett Christ. So, first off, this is my strategy, give you the overviews. We'll do a little bit about what it means to have a hip replacement, why we do it, and how. Give you a little bit of my perspective on this. And we'll go through some of the newer technologies. So, what we're talking about here is a hip that is worn out. Hey, Ben, join us. I kind of went through your family stuff. Do you want to say anything?
No, it's fine.
Honestly, I didn't do as good a job as you would, but
That's okay, no problem.
I didn't say anything too embarrassing, I hope. So, going through hips and arthritis. What we're really talking about is a hip that is worn out. We're talking about the cartilage, which is on the ball of the hip. And I'm going to put this down for a second to sort of visualize this, show this with my hands. The hip is a ball in a socket. It's not very hard mechanically to understand. It's a ball and it's a socket. What is important is the articular cartilage, which is this pink tissue right here on the ball. When that wears away, we call that wear and tear arthritis, osteoarthritis, but that is a very big problem and it's prevalent all through the country. Now, what is it going to feel like if you have arthritis? For a lot of you that are watching, you could tell us. Usually the number one driver is pain. The location may be a little variable. It may hurt you in the front of the hip, may hurt you on the side and the back, may go down into the thigh, but usually the thing that brings folks into our office is pain. Now, it also can present with stiffness. A lot of people will notice they have trouble walking. Maybe it gives them a little bit of a limp. Maybe their toes will want to turn out a little bit. They have trouble getting their shoes or socks on, trouble getting their leg into a car. All possible things that can happen also related to stiffness. Another thing that is fairly typical is that the pain that you have, despite how it presents, where it is or what brings it on, is it tends to be worse the more you do. Where it starts, it might be, oh, I walked a long distance and it gave me pain. As time goes on, it might be enough that, hey, I'm just sitting in my chair and it hurts doing nothing. So, if you go see a doctor about this pain, do you have a worn out hip? First thing they're going to do is ask you the story. How did it start? What kind of trouble are you having? Where is your pain? The key component to this is finding out how this affects you. What is an impairment for one person may be okay for someone else. You may have pain, but it doesn't affect you too much because you're not that active. However, someone who is much more active, maybe has a job where they're on their feet for 12 hours a day, that affects them very differently. And those are the kind of things that are important to figure out when you're visiting with your doctor. Your doctor's probably going to want to take a look at your hip. He's going to ask you to walk to see, do you have a limp? How do you hold the extremity? He's going to want to check that hip that's giving you trouble. Probably check the other one just to compare what it should be like. Check your leg lengths, see if they're off a little bit, because as it wears, it can shorten. And usually you'll check the nerves going down the leg and the pulses just to make sure there's nothing else going on. The first thing we usually do in orthopedics, though, is we get x-rays. We love to get x-rays. I mean, to be an orthopedic surgeon, you don't have to be the smartest doctor in the doctor club. You don't. What you do is we get an x-ray, and it really gives us a good idea of what's going on, and we really tend to base our decisions based on that. So going back to that same slide I just showed, what's important here is the pink articular cartilage. In this picture, it looks pretty good, and the picture on the left is starting to wear away. And everybody talks about having bone-on-bone arthritis when it gets really worn. When that happens, on an x-ray, you'll see as that pink tissue wears away, it'll look like the bones are starting to get closer and closer together as that pink spacer, which is clear on the x-rays, is worn away. And it gives you a fairly characteristic radiographic appearance. Again, good cartilage on the ball, it's starting to wear away, but when you take an x-ray, On the slide over on the right-hand side, still got a good clear space because that cartilage is still there. If you look on the other side, that space is gone. And that's what we say someone has bone-on-bone arthritis has gotten pretty advanced. So, do all patients with hip arthritis need a knee replacement? The answer to that, I think, in my opinion, is a resounding no. It's not something you initially jump into. First, it's important to consider what do you mean by you need a hip replacement. A hip replacement is a quality of life issue. It's not a heart attack. It's not a brain tumor. You need to do this. You need to do this now. This is a quality of life issue when people decide when it's right for them. I will usually recommend some sort of anti-inflammatory medications, perhaps physical therapy, maybe backing off on what you're doing, just trying to get time behind you, because this is not a minor thing we're talking about. For me, the indications of surgery break down to pain and the limitations in what you can do because of the pain, and the conservative, simple things aren't doing it anymore. So, we're going to talk about different approaches for hip replacements. The superior approach, the anterior approach, there's a mini posterior approach, there's lots of approaches. The end result is the same, and this is probably the most important thing to remember, is the parts that go into your hip are going to be the same. It's just which door you're opening to go in and get the job done. It's more important to get the parts put in well, have them solidly fixed. That will give you a good long-lasting result. What we're talking here is things that will make it a little easier on you, speed your recovery, but the more important thing is the job that is done on the inside. And we're going to be seeing lots of pictures about different approaches, and what that boils down to is where do you make the cut in the skin? And I apologize, this slide does not project very well. It's trying to show that depending on where you put the cut, whether you put it on the lateral side, which is the outside of the hip, the anterior part, which is the front of the hip, the posterior side, it's all how you get in to do the work, but the parts inside will be the same. Now, those were the big three that I showed on that first slide. There are lots and lots and lots of ways to do this. Some of these have come and gone. Most of these I've done personally. I tend to do the anterior approach. I will do some posterior. Those are the two workhorses that I will tend to use. Now, if you take anything away from what I have to say, the important thing is this is your decision. Take the time, put out your input. You should be communicating this with your doctor because that's what's essential here. Nobody tells you you need a hip replacement. It should be something that you've come to the conclusion that you need. I would try the simple things first, but it's important to have a communication relationship with your doctor because number one, you're going to do better beforehand. You'll do better during the procedure, during the recovery, and if God forbid something were to pop up, oh, you had a blood clot or some kind of skin problem or something like that, those are the times you need to be communicating as well. So that's a good thing to establish at the get-go. Do not be shy about speaking up. If you have questions, it's your hip. They should be answered. You're the one that's going through this. It's our job to help you. And again, and to close, I would say we're going to talk a lot about high-tech, really cutting-edge ways to do this, which I'm pretty pleased to do. I'm happy. But the most important thing is find a procedure that your doctor does well and have him take his time and do a good job for you. That's it. I'm going to turn this over to Dr. Aggarwal.
Thank you, John. I will take that from you. Thank you, John, for giving a nice overview of how patients present and how we approach. The key thing, as John stressed out, how the components are well positioned, that determines the life of the prosthesis. So I will go over some of like posterior approach or that I do over here in selected patients. So I'm going to touch base little bit mini posterior and direct superior approach. The key purpose of these approaches are, sometimes we can shorten the recovery in the first 6 to 12 weeks. That's the main difference, out of all these approaches. So the direct superior approach is a minimally invasive approach in hip replacement, and I prefer in very young active patients and who has a normal anatomy. not in some patients who has like very difficult pathology, I may not prefer this approach. This is a muscle sparing approach for hip replacement. It's developed to minimize the damage to the soft tissues that are critical to the functions. The superior approach was developed to allow the surgeons to avoid cutting key muscle, and the main structure that we avoid cutting in this approach is IT band and some external rotators. So those are the critical components. In the first few weeks, that may decrease their rehab and improve their quality of life much faster. That's the main advantage of this approach. The direct superior approach allows your surgeon to minimize the damage to the IT band. And here is a picture we can see of the IT band, which refers to iliotibial band. And in this IT band, normally in anterior approach, we don't even touch this. So this is a kind of a band. It helps to improve their recovery much faster. So there are two pictures here. We can see the traditional hip replacement, which is like kind of a posterolateral hip approach. The classical incision in that can range from 10 to 20 centimeter, depending on what's the surgeon comfort level. In old times, I would say in 80s and 90s, the incision used to be around 15 to 25. Nowadays, it's more around 10 to 12. And mini posterior, or like direct superior approach, it can range from 8 to 10 centimeter incision. So here you can see the traditional approach, how big the incision is, and direct superior is mainly from the initial part of the incision in the traditional approach. So what are the advantages? It's a smaller incision. It was developed to perform surgery for surgeons who are comfortable with the posterolateral hip approach. So somebody who has a good experience in posterolateral, they can adapt much faster in the learning process. And as I mentioned, a traditional hip replacement requires a bigger incision. Still, I would say traditional or mini posterior are still gold standard for as far as approaching the hip from the back. But comparing the anterior incision and direct superior, they are like counterparts from the front or back. So what are the benefits of this approach? Less muscle or tendon damage, no hip precautions after the surgery, and these may be performed in selected group of patients as an outpatient surgery with a shorter span of the stay. Lower dislocation rate and very minimal pain after the surgery. This also helps in their reducing the blood loss and also the medications required for the pain and lower complication rate. So in summary, direct superior approach is a complete preservation of the iliotibial band. It helps in the pelvic stability, reduces the postoperative pain, and much faster recovery. This is the cornerstone of the quicker patient recovery. So again, in summary, wherever we approach, as John mentioned, the key thing is how well the surgery is done, how is your experience to execute these approaches. Otherwise, all of our goal is to get outcomes which the hip can work for 20-25 years. Now I will hand over to Ben. He will talk about the anterior approach. Thank you.
Okay, thanks, Dr. Aggarwal. Okay, so I agree with everything that both Dr. Nettrour and Dr. Aggarwal said about hip replacements. It really is about what goes on inside. Putting the components in the correct position, getting the leg length correct, restoring getting the hip to be stable, so that the hip can function properly for a long period of time without excessive wear and without problems with dislocation and stability, and without the problems of loosening. So these different approaches are different ways to get the job done. Hip replacement can be done very well through all of these approaches that have been mentioned. But I'm going to talk specifically about the direct anterior approach because that's the hip approach that I use on the vast majority of the hip replacements that I do. When I trained, I learned with the posterior approach, and then I learned how to do the anterior approach, and I've kind of shifted my practice to do more with the anterior approach now because of some of the advantages that I'm going to talk about. I think there's some definite advantages for the patient in terms of recovery, like Dr. Aggarwal said. So the direct anterior hip replacement is just a picture showing the different roads that can be taken in order to access the hip joint. So this is a right hip facing forward, showing the muscle planes, and the one right in the front there is the path that we take to get to the hip with the direct anterior approach. We can just, it's in between the muscle, intermuscular plane, and we just divide the muscles and we get right on the capsule. So this is another picture showing those two muscles, that the tensor fascia muscle and the sartorius. We divide that, go in between those two muscles, and we're right on the hip capsule. Okay? Another picture showing that. And then this shows the table that we use and the patient on that table. So that's the position that the patient is in during the procedure, working on the left hip. It's showing the left hip with the feet down towards the left and the head up towards the right. Okay? So the a few of the anatomic advantages of the direct anterior approach. Like I said, it's intermuscular. We go between two muscles to get to the hip capsule. We don't have to cut any muscle away from the femur in order to access the hip joint, which gives us some advantages in terms of early pain control, early recovery, and stability of the femur and stability of the hip joint. The hip in the front is closer to the skin, more superficial. We don't have to go through the backside, through all of the sometimes extra tissue on the backside. The abductors are preserved. So the gluteus medius muscle, gluteus minimus muscles on the side that help to bring the leg out to the side don't have to be cut. Okay, they don't have to be removed from the femur. That helps with postoperative limp and makes that less common. The iliotibial band is preserved, and then the external rotators can be preserved as well. The muscles along the back of the femur that rotate the hip and help with hip stability. And then the other thing that's a big advantage is the images that we can get in surgery to help with the accuracy of the components, making sure that the socket is in the correct position and that the stem is in the correct position and the legs are in the correct position. This just shows a picture of kind of how the room is set up with the patient on their back. The X-ray machine or the C-arm can be brought in to get accurate images. We don't use the postoperative dislocation precautions because those muscles are not removed from the femur. And so this just shows a picture of a right hip, okay? The back side of a right hip, okay? This just shows the muscles that attach to the back of the femur. So if you approach the hip from the back, those muscles have to be cut, or some of those muscles have to be cut off in order to gain access to the hip joint. With the direct anterior approach, we can avoid doing that in most cases. Okay, so these are the intraoperative images. So this is we can do this in surgery. We can get these images to check component positioning and to confirm that we have the leg lengths correct and the hip stable. So what we do in surgery is we take a picture of the non-operative hip, and then we trace out the bony landmarks on the pelvis and the femur. And then we can do that with the side that we're working on, with the trial components in position. Okay? Again, trace out the pelvis and the femur. So two just anterior radiographs or fluoro images. We print those out, and then we can take the one and flip it over and superimpose it on the other and line up the pelvis, and then we can check to confirm if the legs are the same length. If they line up perfectly, then we know that the legs are the same length. If the side that we're working on is too long, then we're right in there in surgery. We can make changes. We can change the length of the head. We can put the stem deeper. We can sit it more higher to adjust the leg length. So that's a real advantage for me as a surgeon. I feel like I'm more precise and more accurate in how I can perform the surgery with this technique. Okay? So I get asked a lot what I can do after surgery. I tell folks that they can go back to the activities that they enjoy doing. These are made for walking, low-impact activities, golfing, playing tennis, swimming, biking, dancing, things of that nature. I tell folks to avoid the extremes, such as marathons and football and basketball and soccer. We do these sometimes in people that are younger because of post-traumatic arthritis or avascular necrosis. It's not only arthritis. This is a friend of mine who had an accident playing football and sustained some trauma to his hip. He was about 39 years old when he had his hip replaced, and he sent that picture to me when he was skiing in the Alps 8 weeks after his hip replacement. So he was doing things that I told him not to do, but just for longevity of the hip replacement, if you avoid the extremes, the hip is going to last longer. Okay, it's going to last longer, and so we tell folks to avoid the extremes and return to low-impact activities for the longevity of the prosthesis, for the longevity of the hip replacement. Okay, so a total hip replacement, regardless of the approach you use, regardless of the path that you take to get access to the hip joint, it does provide predictable pain relief and improved function. It can help preserve independence, return your normal lifestyle and your normal activities that you like to do. It can improve your psychological well-being and return to the desired activities that are important to you. And that's really the purpose of the procedure. And it can be done, and I agree with what my partners have said about the approach can be important for certain aspects, but it really is more about getting the components in proper position, getting them well connected to the bone, well fixed, and in proper alignment. And that's the most important goal with a hip replacement. Okay, thank you. That's all I had for the anterior approach. We can take some questions now if there are any questions. Do you have any questions?
What would you suggest? What approach is better for someone that has an abnormal bone structure?
Well, it really depends on what the abnormality is.
You have an elongated.
Like a elongated neck.
Yeah.
Like a long. I think you can do so. I'll do an anterior approach it's well over 90% of the people that I do hip replacements for. I will not, so it's really the people that I won't do an anterior approach on are, so it's kind of a soft tissue issue. I mean, with an incision on the front of the hip, if there's a lot of skin that hangs over that area where it's going to be hard to take care of, I will avoid that, and I'll put them on and do a posterior approach, like a mini posterior approach on those people. I guess if they're bony abnormalities where I would not do an anterior approach, I honestly can't think of any off the top of my head. I haven't shied away from an anterior approach for that reason I can't think of, off the top of my head, I can't think of a bony abnormality where I wouldn't do an anterior approach. John, can you think of one?
I think that's a great question, and it gets to something that's a bigger issue. When you ask that question to Ben Hansen, you've done this a lot of times, Ben. How many times have you done an anterior approach on a patient?
Oh, probably a couple hundred, 200-300.
Yeah,
Yeah.
we're actually presently writing a paper on the anterior approach, a technique that we're going to submit in journals on how to teach other docs how to do some of the tricks, because I've probably done this 1,000, 2,000 times. You're asking that question to people that have done this a lot, and we're going to be much more likely to say, yeah, I'm pretty comfortable doing an anterior approach for this, because it's like anything else. If you spend all day, putting up wallpaper, and you've done that for 10 years, you're going to be pretty good putting up wallpaper for a while, and not a lot's going to, a little curve in the wall, you're going to be able to get around it. The specifics of your question, though, it's hard to know, but for almost anything, I would try to use a minimally invasive approach. I would. But you can't say that for sure because you really want to see the details. My hunch is it's not something, oh my God, this is a huge abnormality that differentiates you from the other 6 billion people on the planet. Probably not. But you really would want to see just to, give you the answer that the question is due. And the same thing with Dr. Aggarwal. You've been doing this for years, Ajay.
Pretty much same. I would say it depends on surgeon preference, how well they can execute that approach. In my mind, approach is for a few weeks, but key thing is how consistently you can do thousands of operations the same way, get your best outcome. So I rarely change my approach. I go more from the side, like push back, but I've done thousands. That's most consistent in my hand. Like I want same outcomes on all my patients. And my partner, they do anterior. And the key thing to understand is we have done thousands. So that's where the experience comes into play. If how well we can execute that joint. It doesn't matter to me anterior or posterior, how comfortable you are. My training was in posterior. That's what I did in my whole fellowship training. And, I follow that. I can get the same outcome on every single patient.
Yeah. I think for those of you also watching on Facebook, and an issue that we have a fella here that is considering it, but and one of the special conditions is when we have patients that are very young, because it presents two different issues. Number one, the activities, and I thought Ben did a nice job going through there. What kind of things you should do with your hip replacement? What should you not do? I agree with a lot of what Ben said, but I'm not sure everybody entirely agrees with us. We went to a meeting of the American Association of Hip and Knee Surgeons about, I think it was a year and a half ago, a meeting before this last one. And they did a live polling of the people who do hip replacements. How much do you let your patients do? Do you let them walk a long ways? Do you let them dance? Do you let them ski? Do you let them run a marathon? And not everybody agrees. And the answer is we don't really know. We think what we're trying to prevent is we're trying to prevent you turning your 30-year hip replacement into a 7-year hip replacement. That's what we're trying to get. And particularly when patients are really young, you don't want to be redoing hip over and over because you can start to run out of bone. But the implications of everybody's case is a little different. So if you're coming from that perspective, is yes, you're younger, you want to be more active, have a real discussion about that with your doc. Their opinion might be a little different than ours. It doesn't mean they're crazy. It just means they might have a look because we don't know the answer to that. But that's a discussion you should really have with your doc as you're sorting through this.
Yeah. And the thing that I've found that patients are really interested in are what physically are they going to be able to do? Like, what can I do? You can do extreme. You can. This guy returned to skiing at an incredibly high level, way better than he was before he had the hip replacement because he couldn't move the hip. You can run, you can ski, you can water ski. Physically, you'll be able to do those things. If you could do them before, right? You're not going to pick up new sports, but you're going to be able to function at that level. So, but the question is, what are the consequences of that, right? What are the long-term consequences? We don't 100% know. So it goes into, what kind of a risk taker are you? And what kind of a risk taker is your doctor ultimately? You feel comfortable saying, yeah, you go ahead and go water skiing? Well, if something bad happens, it gets multiplied if that bad thing happens with an artificial joint in place or around an artificial joint. So in my mind, I'm a pretty conservative guy, and I think it's err on the side of caution. Even though you feel like you can go run a marathon, I don't think it's a great idea to do that on your artificial joint.
And we've seen some pretty active patients.
Yeah.
And I think of one that you have. this takes us back as doctors. We have to be careful what we tell people. I had one lady who was very active, and she used to enjoy running long distances, was very competitive at it. Said afterwards, you should really switch over to something else. This is not the best to be impact loading this over and over again.
Yeah.
Why don't you take up bicycle riding? Cycling. Bicycle riding makes it sound competitive cycling. And she then she competed at a national level, cycling hundreds and hundreds and hundreds and hundreds of miles
Yeah.
with 2 replaced hips. So be careful what you ask for. And I know you've had one in particular that I think actually may be more active than you wanted to, but
Yeah.
people can do
Yeah. Yeah, I
an
mean,
awful lot.
I had a knee replacement patient who, when I was working in Salt Lake, and so we're talking about hips, so,
Yeah.
but a knee replacement patient who my partner replaced his knee, and he came to him because he had end-stage arthritis of his knee and wanted to summit Mount Everest. I mean, he couldn't train like he wanted to train, so he got his knee replaced and had end-stage arthritis, but wanted to keep going and got the knee replaced, and then a few years later, I did the other knee, and then a year and a half after that, he summited Mount Everest with 2 artificial knees. So, is that advisable to do? Probably not. If something goes wrong on the top of Mount Everest, he could die. But to him, that was his life. I mean, he needed to do that. He wanted to do that, and the knees functioned well enough for him to train, and he accomplished that goal with those knees. Now, so you can do remarkable things with these artificial joints and these replaced joints. I mean, they can function at a very high level. Yeah. Yeah.
I'm a bigger guy and was wondering if, the bone structure of that ball and socket area, because I'm bigger, would my bones be different sizes than other people's? And if you're going to get a replacement, are there different sizes of the components that go in there?
Yeah.
Oh, yeah. No, just you. Oh, to repeat the question, we were asked, we got a question from a fellow who is a larger fellow asking, do hip replacements come in different sizes? And the answer is a resounding yes, absolutely. Putting a hip in a larger fellow like you, yeah, is not going to be the same as a 5 foot, 89-pound young lady. They are just like shoes, okay? By the same token, sometimes if folks are bigger, it makes a difference not only the size of the parts, but it's one of the things that makes it harder to do some of these smaller incisions too. I mean, it's harder to do the work. They have to be, the first step is you have to get the parts in the right alignment. To do a wonderful operation to a tiny little incision, oh, by the way, the parts are a little crooked, that's a bad trait. I'd much rather have on myself a big incision and the parts put in as perfectly as possible. So I think you really need to talk to your doc and say, hey, this is my particular case. This is who I am. This is what I like to do. What's the best for me? And you might get a different answer because the other half of that equation is your doctor saying, hey, in my hands, this is the best job I can do for you. I mean, at our academy meeting in March, I believe it was the chairman of orthopedics, he's a hip replacement subspecialist at Mayo Clinic, got up and he says that a technique called the mini posterior incision, he still believes is the real way to go for folks. And the key to that is, yeah, there's a lot of truth to that. And in his hands, he does it really, really well. But that's where you tailor it to be the needs of the patient versus what the surgeon does well, and you come to an agreement on that. And the answer is different for every single person. So.
And there was another question the audience asked about the bone sizes on big versus medium-sized patient. It doesn't. It's interesting. It's very different. Some big patients, like tall patient, may have big bone size, but some patient who has a high body mass index may not have a bigger sizes. And normally, size doesn't cause arthritis. Like there is inherent some mechanical block in the hip in young patient that causes damage to the joint. It's not the size of the bone. Like we have a young fellow, 44, but sometimes that, like if you have a malalignment in a car tire or there's imbalance, the trade is going to go off very fast. The life of that car tire is going to be much less because there is a block in the hip joint. So that's what causes arthritis in a younger patient compared to, somebody in mid-60s or mid-70s, it may not. So, there is a block in the hip joint that causes arthritis in a younger patients.
About how long does it take for most patients to get back to a normal level of like baseline activity after their surgery?
A normal level of activity following surgery. So the question was, how long does it take most patients to get back to a normal level of activity after the procedure? That's a loaded question. And I know you didn't intend to it to be, but we'll see some folks that really suffer. I mean, you see some of these folks that are just tougher than nails, have been putting up with a worn-out hip for 20 years. And you watch them, it just, in the office, it almost makes you want to cry, watch them try to walk. I mean, things I would never put up with myself. You see some of those folks will come in, and the day after you do their surgery, they walk out. I mean, I had a patient that was still in the military. It's just absolutely stunning what he would do on this worn-out hip to not give in to do it. So when we did his, I mean, he walked out of here 10 times better than when he walked in the door. What I think you're asking, though, is what can I expect in my recovery? For these minimally invasive procedures, in general, there's not a lot of time in the hospital. Years ago, we would check you in. You'd be in the hospital 3, 4, 5 days. I mean, I'm old enough. We did. We've gotten a lot better at this over the years. So most people, they would come in. You do your hospital. Here, we usually keep you. I'd say the average patient stays maybe overnight and goes home the next day. We let you walk on it as much as you want. Afterwards, I ask folks to use as a crutch or a walker or something for balance because you're not used to having the hip move as easily. But we like to see people walking pretty well the day after we do it. Before I let folks go, I like to see them get in and out of bed. You've got to be safe at home. You've got to be able to get to the bathroom. You've got to be able to go up and down some stairs. Be able to, I mean, if a family member runs an errand to the gas station, you've got to be safe. We like to see that before you go. Most people are walking pretty well in about 2-3 weeks. There are exceptions. Some of the minimally invasive ones, I've had people go back to work the Monday after we did it. There are some that are just sort of off the chart, but that's not, I think that'd be wrong to assume that for everybody. I like to see people walking really pretty good by about 2, 3, 4 weeks. However, if you ask folks, hey, do you feel like you're recovering? No, it's still stiff, it's sore. You're improving every week, but we like to see you pretty much through it by, I'd say, maybe 6, 8, 12 weeks. But then if you pin down somebody that's ever had a hip replacement and say, hey, when did you feel like you were done with this? Fully recovered. People keep getting better month after month after month for literally about a year after we do this. But we like to see you getting around really pretty good by 2-3 weeks, but you're going to keep getting better and better for a full year, I would say.
Yeah.
So there's a question from Facebook. Somebody wants to know how,
Yeah.
there's a question about how hip pain looks like, comments.
How what?
How hip pain look like.
Oh, okay. I can go through. Hip pain looks different for different folks. I mean, I think the question, if I'm understanding this correctly, and if we're not, please type right back in and we'll redo it. But what does hip pain look like? It looks different for different people. Typically, where most people will feel it is the front of the hip and the groin. It'll ache down into the thigh. However, that is not by any means everybody. I mean, for the next person, it might be the side, it may be the back. Typically, it's worse the more you're on it, but it can present very differently. In my experience, you've really got to sort it out. And it sometimes as doctors, this is going to mean kind of embarrassing, but you see this. It can be hard to sort out what exactly is hip pain because a lot of folks will have trouble with their lower back. And we'll see folks come into clinic and say, oh, I'm here to get my hip checked out. And you'll go and say, okay, show me where it hurts. And they'll come and they'll show you, like, sort of over here, which, okay, that makes me think the hip. But then they'll show over here, which makes me think the back. And a lot of times it's tough for us to exactly sort it out. What you don't want to be is have someone do a procedure where they never really sorted out exactly what the problem was. So in my hands, I really want to pin it down and say, okay, where do you hurt? When did it start hurt? Does it fit with what I normally see? Do the x-rays match? Take your time sorting it through at the beginning so that you can really get people where they want to be doing what they want to do. Spend the time up front. I don't know. Did you have something to add, AJ?
No, nothing to add. That is, thanks, John. There's another question I would like Ben to comment. Question is, will the pain radiate down the leg, groin and lower back if there are some issues with the hip? So I'll repeat the question again. Will the pain radiate down the leg, groin and lower back if there are issues with the hip?
Yeah. So, can you have pain radiate down into the leg? If the pain is originating from the hip joint, from the ball in the socket joint, can it radiate down the leg and maybe to the knee? Yes, it can. In some people, it can. I have had patients where they present to clinic with knee pain, and they just say, "Hey, my knee hurts. I'm here to get my knee checked out because when I walk and I can't stand this knee pain." And we get X-rays of the knee, and the X-rays of the knee are normal, and we examine the knee, and the knee feels fine. Examine the knee is normal, and then I move the hip, and they scream, "Ah, my knee hurts." And then we get X-ray of the hip, and the hip's worn out, severe arthritis in the hip. So you can have that. Sometimes it does take some Sometimes we do injections into the hip, into the back, maybe the knee, to sort out where the source of the pain is. It's very important to make an accurate diagnosis before we recommend any treatment option. And sometimes it can be not exactly straightforward. Sometimes it can be difficult to precisely find out where the source of the pain is coming from because it can radiate. You can have pain starting in the back, radiating to the hip, or down into the knee. But that's our job to help sort that out. You get the imaging studies that we need. Sometimes it does take some injections in a few places in order to precisely figure out where the source of the pain is originating from. Where the pain is originating from. Yeah.
That's a very hard question for us. I mean, you see a lot of overlap. Can a pain from a pinched nerve in your back radiate down your leg? Yes. In general, a good rule of thumb, but not all, a good rule of thumb is if your pain goes down the leg and it goes past the knee, it's probably or more likely be coming from a pinched nerve in your back rather than the hip. Typically, the pain that comes down from a hip, down the leg, will tend to stop in the knee. And that's just sort of a rule of thumb that we'll use. But it's really worth the time sorting that out up front. I mean, I had a gentleman here that I just saw for a second opinion. And he had some arthritis in his knee, and he was going to get a knee replacement. I mean, the pain was in his lower leg and knee. And I saw him, I think, yeah, he did. He did have some arthritis in his knee, but boy, he limped horribly, just much more than you would ever think. So we x-rayed his hip, and boy, that pain that he thought was coming down the leg and in his knee was really coming down from the hip. So a test injection is a wonderful way to sort this out. I use it a lot. It sounds like you do a lot, Ben, AJ, because we will get confused, and you do not want to have a wonderful hip replacement for a pinched nerve in your back. That is a bad deal. I mean, does it happen? I mean, I'm sure it does. I'm sure. But you want to take the time up front and do the test injection. Make sure you're, solving the problem at the right spot.
And I totally 100% agree. That's a great question, And a lot of time, not many people can figure out whether this is a hip pain, back pain. And that's where, we spend a lot of time, and that's our day-to-day. Even if you see some, different surgeons or primary care physicians, it's very hard. So that's very, very important to differentiate where it is coming from. Yes.
If we see you and it ends up being something else that's not a hip or a knee, can you send us to the proper doctor that would help us with our spine?
No, you're going to get a hip or a knee replacement.
No, I don't think anybody.
So the question from the audience was, if this is not a hip and knee, where do we go from there? I'll start that, definitely. And that's what we at Missouri Orthopedic Institute offers, a comprehensive team approach. And we have subspecialties whom we rely 100%, whom we should refer to. And that referral is very, very important, so that their patients can have, particular treatment, whatever is needed for.
No, this is a comprehensive place, whether it's your back, your hip, your young or old, or however many birthdays you've collected in your life. Yes, you're going to get steered the right direction here. And the one thing that I think is important is we're talking about comprehensive care, particularly with young people here. I think it'd be worthwhile, AJ, if you could just say a little bit about, you do things that the average hip reconstruction surgeon does not. We have things offered here that you're not going to find at most places. You mean younger people who come with, maybe they don't need a hip replacement, there's other things you can do because you have special training in this.
Sure.
I don't know if you could speak a little bit to that.
And that's where, we have a comprehensive team approach. We coordinate with our trauma folks who has post-traumatic damage to labrum, cartilage, or pediatric folks. Sometimes we have childhood problems where we work as we have a hip preservation team, me, Dr. Brett Chris, we work together to delay the progression of arthritis, and that's very critical. If we catch those patients at a reasonable time, we can buy or, delay the hip replacement by 10, 15 years. But the key thing is the joint function should be good before we catch that.
Anything else you'd like to add into that?
No.
Okay. Now, specifically, anybody in here that you can think of? Because, we can talk about a lot of stuff.
All right.
And I can
Got a
try
list of stuff.
I can
No,
try
shoot.
to our one particular case here. It's almost like, what can we do? Because these are some of if I were you, these are some of the questions that maybe I would ask, kind of stuff. Because whether you choose to see somebody here or you have got an excellent surgeon where you're getting care, the more education you get, the better. So,
What do you tell your patients to prepare? How do you prepare them? Like, okay, I'm thinking about getting a hip replacement. What can you be doing before you do it? Like, oh, you need to be stretching, or you need to be walking, you need to be active. Hey, don't take it or take it easy. Maybe do the opposite.
Yeah. No, I tell.
Lose 10 pounds.
So that's a good question, and some of it's individual.
well, I think you better tell the folks on Facebook what the question is. I
Oh,
think they
that's
can-
right. So the question is, what do we tell our patients before surgery? Should you, specifically activity level, should you be doing certain exercises, physical therapy? Should you lose 10 pounds? What do you tell your patients in order to prepare them for the hip replacement? Was essentially the question. So opportunity here to talk about some of the things that we counsel our patients on. This surgery does have risks, okay? And one of the risks is infection. And so you mentioned losing 10 pounds. And so there are patients that we will ask to lose some weight before doing the hip replacement. And the reason is because we want to minimize the risk of complications after surgery. There are certain risk factors that have been identified that are modifiable, meaning we can change how we can change them prior to surgery. One of them is the weight. So if somebody is significantly overweight, losing weight can help them lower their chances of infection, lower their chances of post-operative complications, having a problem after surgery. Getting your diabetes under better control. Having uncontrolled diabetes is a risk factor. Smoking is a risk factor for infection. So those are things that we will counsel, when it's appropriate, we'll counsel patients to do prior to surgery. As far as activity goes, I commonly will refer my patients to physical therapy to work on strengthening, to work on stretching, to get into the best shape that they possibly can be in before having the surgery, of course. Now, there'll be some limitations to that, obviously, because of the disability from the arthritis. But I think whatever they can do to maximize their ability to move and to walk and to be mobile is going to benefit them after surgery. Same thing goes for knee replacement patients.
That's a good question and a harder one for us to ask. I mean, correct me, you're asking, like, in your case, what would you do before doing this so that you recover the best you can and smooth as possible? You'll get different.
Do I push myself to, like,
Do you push yourself
or
to?
do I hang?
Okay. The answer is different for each person. And I'm in your particular case, I don't think it's going to matter that much. And I do that not to, but just to boil it down, you're probably going to be in pretty good shape. You're on the younger side. I mean, you could go to rehab. Is it going to make a monumental difference in how you recover? No. You're going to recover pretty well. You've got to tailor it to the person.
Absolutely.
On the other side, most people will. I'll agree with Ben. Most people that have an arthritis, it's gotten weaker. They don't get around as well. But you've also got to watch the folks that have a really bad hip. Sending some of these folks to get conditioned at therapy. Have some therapist forcefully moving their severely arthritic hip. Some people it really hurts.
Can't do it.
So you've really got to watch. So like the direct answer to you is, I don't think it's going to make a big difference. You would recover very well, I think, regardless. But you got to tailor it to people because some people it really does help.
So I have another very good question from one of our audience. How can people prevent the need for hip replacement or knee replacement? And let's limit our answers as short as possible.
How can you prevent a knee replacement?
Hip and knee replacement.
Hip and knee replacement.
The need for hip and knee replacement.
I think someday they will figure it out. It will be some incredible scientific discovery with genetic engineering. Right now, if anybody here can figure it out, or someone at home, they'll be one of the biggest gifts in the history of mankind medical discoveries. I would say part of it is just your genetics. You can't control that. Try to keep your weight down, just the wear and tear over the years. Hopefully you're lucky you don't have a big injury where you get arthritis setting in after an injury. But that is an answer we just don't have a solution to right now. That someday they'll look back and laugh at the things we thought and did, but that's another day coming.
Yeah, there's not really anything that you can do to prevent it if other than an accident, post-traumatic arthritis is from, a fracture of the cartilage of the hip or the knee. So if you can prevent those types of injuries, but I never tell anybody to become sedentary, right, to prevent wear and tear of their joints, because the consequences of not moving and becoming sedentary are much bigger than wearing out your joint and needing a hip replacement or a knee replacement. Stay active, live your life, try and avoid major injury, but everybody does that obviously, but there's not a pill you can take to prevent this from happening. A lot of it's genetic, a lot of it's bad luck, bad fortune, and that's what we're here to do, in those unfortunate circumstances, to give somebody a new lease on life. It's a very rewarding thing to be able to do. I mean, I just came from over in the hospital. I know Dr. Aggarwal said be brief, but it makes me think of this hip replacement I did a few hours ago. A young guy with avascular necrosis of his hip, so the femoral head was dying, the bone dying, and severely disabled. Young family, young guy, and he got his hip replaced, and a few hours afterwards he's laying there in the bed, and I come around to the hospital, and he starts moving his hip like this in bed. He looks over at his wife, and he's like, "Oh, babe," like it feels like just immediately better. Just so he's got a new lease on life, and to see it in his face just a few hours after surgery, and there's nothing that he could have done to prevent that. He got bad luck.
So one comment on this, just what to prevent the need of hip and knee replacement, as John and Ben mentioned. We cannot prevent, but the only way one can delay is, have an active, healthy lifestyle. Not being overweight, exercise. There are some things which are inevitable, like in young patient, if they have arthritis, if they're bone on bone, we exhausted everything, then they will need hip replacement, and that can improve the quality of life. So another question, do you recommend postponing hip replacement if the person is 50 years old, if they are experiencing multiple dislocation, pain 60% of the time? I don't know the exact, um, what does the audience or like they mean by dislocations. Normally the normal hip, until it's post-traumatic, it's hard to dislocate the hip. Um, you know, Another question from the same person: do hip replacement last 15 years? I will hand it over to John regarding the life of the hip replacement.
Yeah, I think with most of the modern bearings we use now, I would expect to get 20, 25 years out of these. I would. We used to say 12, 15 years, but the parts are better. About 10 years ago, the folks who make hip and knee replacements started improving the components. The plastic, they were doing special treatments to it called cross-linking. So the parts we put in now are much better than we used 15, 20 years ago. Do we know that they're going to last 30 years? We don't know. The new parts we've been using, we know in sort of what we call midterm data, 8 years, 10 years, that, hey, they're holding up better than the old plastic. The parts are holding up better. Are they going to last 20 years? Yeah, we think so. We don't know, though, because we haven't had them out that long. Are they going to last 25 years? We just don't know. It brings up a whole other thing about what we call bearings. Do you use a metal ball, a ceramic ball? I mean, maybe someone has heard it in the past, people would have hips that were made of metal on metal. There's lots of different options, but that's an individual discussion you should have with your surgeon. And I wanted to go back, because the one question someone asked about recommending postponing with hip replacement
Until
50.
50 years old.
If we generally tell people that if you can postpone it, the simple things are working, the arthritis medicines, therapy, things are able to keep you going. And if you have a decent quality of life, you're enjoying things, yeah, I would try to postpone that. However, in your particular case, I mean, as far as I know, life is a one-time deal. I don't want you to skip all the things you love in your life because you're over 50 years old. I would sit down and say, hey, these are the specifics of my case. Come in and talk to an orthopedist here or somewhere else. But with the specifics of that, I would take the time and just really get an honest opinion about your particular case.
Yeah, I agree. I don't have an age on the young side or the old side. It's a very individual decision. It's not a number in my mind.
And I do have a young hip practice. Once we exhaust all non-surgical measures, that's one of the best operation. There's a difference in knee replacement. We try to delay the knee replacement as long as we can, which is little different than the hip replacement. We have one question about the recovery. Has the recovery time improved if you have a hip surgery? If yes, is it due to technology and physical therapy? John?
I would say all of the above. I think physical therapy is better, but I think I'll tilt my answer a little bit. I think the real advances we're seeing in the recovery times are due to we're getting better at this. We don't have to pick on people as much. Smaller incisions, less injury to the muscle, they're recovering faster. But it's also, even our colleagues that help us in anesthesia, we're better with medications afterwards. People don't hurt as much. We do cases a lot with blocks now, so people aren't as nauseous and sick afterwards. A lot of really good advances have come by for hip replacement, which has really facilitated this. So,
Question for Ben. Tell us, Ben, about hip dislocation. One of the audience asked, hip pops out of the place after replacement. What is your experience and incidence?
So it can happen. It happens rarely. It's more often it happens once after a redo, or we call it revision surgery. If you've had to have a part taken out and replaced, then it happens more often after that. The incidence of hip dislocation is, extremely low. I mean, way less than 1% in my experience on a primary hip replacement.
Throughout history, that's one of the things that is different. We used to say that the incidence of replacing a hip, having it ever pop out of the socket, is about 1%. That's one of the things driving some of the new techniques. We think with anterior hip replacements, it's lower than that. But we've also learned that some of the older techniques with a posterior hip replacement, if you go back and you repair a lot of the tissues well, that maybe you took down a little bit of to do the thing, then the dislocation rate drops as well. But it should be really pretty low. It's not a common thing. However, when it does happen, yes, it's a very big deal. So I've had very low rate, and I'm very happy about that because it's a hard problem to deal with afterwards for both the patient and the doctor.
I totally agree with Ben and John. One thing to add, it's not the hip replacement which determines risk of dislocation. It's surgeon experience is very important, how well the hip is done. It can vary from institute to institute and person experience on dislocation. There's a question about if one has experienced infection in a previous pelvic surgery repair, is that a concern for hip replacement or a reason to not pursue? So infection in previous pelvic surgery or repair. I'll start answering. It depends how bad the infection was. Anytime there's an infection in the system or in the body, that patient already is at a higher risk. Sometimes they can be carrier for bug, so we try to determine why it happened, what's the status of that infection, and yes, that's always concern for hip replacement, but it's not a reason for not to pursue. After proper investigation, we can determine how is the risk. John?
This is one where the details are really important. What kind of infection was it? Was it a staph infection? Where was it? How was it treated? This is a tough one to generalize. This is one that you would want to sit down and go through all the information you can. You would want old records about it. And at the Institute here, we have one of the things is we have infection specialists. We see a lot of folks come in that are referred in for things that had problems, either a hip that dislocated or someone had an infection after a knee replacement. Things, when they need a higher level of care and that they're tough problems, we tend to see a lot of those things here. And one of the services we have available is we have some specialists in infections that will come and see folks in the clinic here just to make it easier for them. So I guess that's a very roundabout way of answering that it could be a big deal. You really want to get the specifics and go through them with your doctor because it really impacts it. And if you have an infection in a replaced hip, it's a big deal. And you really want to do all your due diligence and homework ahead of time to make that as least likely as possible.
Yeah, I just add, so depending on the details, it could be that you're not a candidate for a hip replacement if the infection was bad enough, or it could be that it would be a reasonable thing to do. So it really is in the details. And along the lines of infection, it's one of the biggest things that we worry about as hip replacement and knee replacement surgeons, because if an infection in a replaced hip is not something that can be treated with just oral antibiotics for a couple of weeks. A lot of the time it requires going in and removing all of the components in order to eradicate the infection. So it is a big deal. It's something that we take very seriously, and we do lots of things to prevent the infection from ever happening in the first place.
Just for the audience, John, Ben, what's the incidence of infection in a primary hip replacement in your practice?
In my practice,
Yes.
I used to be able to say I never had a hip that was infected. I don't think that's true, and the thing is you never really know, but I would say a couple out of thousands. By the same token, I mean, when you're talking big the same thing with how often do you see a hip that popped out? Not really often. I mean, if you've been doing this a while, you've been trained well, you keep your skills up, you're careful, you take the time to do the job right, it shouldn't be very common in my opinion.
Yeah, I can, a couple. I
Yeah.
mean, a couple. I mean, we just got our infection,
I've had a couple meetings.
infection control data handed to me from the hospital last year that I didn't have any. So
Yeah.
knock on wood. So it's pretty low.
No, I can think of, in the hip, a couple, less than 5, I would say.
And we did our institutional MOI analysis on the hip. It was like 0.1%. And again, I stress this determines the institutional experience, surgeon-wise, how the risk of infection varies from institute to institute. There was another question from the same person. The pelvic infection was MRSA. Does that change? MRSA is methicillin-resistant Staph aureus. Does that change your regarding the views about the hip replacement? I will have all three of us comment. I will start. Yes, MRSA does change, but again, it requires thorough investigation. The bug determines whether the person is colonized or not with MRSA or not. That can determine whether patient is a candidate for hip replacement.
No, again, this is really in the details, and there are certain bacteria that are just harder to treat, one of which is MRSA. Does it say, no, you can never have work done on your hip? No. But you really got to be careful because the stakes are pretty high, because that's one that can get you, and you really got to be careful.
Yeah, I agree. MRSA is one of the bad players, and so it depends on the length of time that the infection was there, where in the pelvis the infection was, how was it treated, and the health of the person, the status of, we call it the host, the status of the host. If the person is poorly controlled diabetes, several medical problems, just overall not a very healthy person, then that's different than somebody who doesn't have those medical problems, who doesn't smoke, who doesn't have diabetes. It's a totally different ball game. So the whole picture comes into play. It's really hard to make a generalization in that regard.
Ben, can you, or if can one of you comment, what's the term refers? There's a question about what is primary hip replacement for audience. What is primary and how it differs from revision?
This real simple operation, the first time you've had a hip replacement done, that is your primary procedure. Procedure number 1, the primary one. If you ever have to go back, revision just means redo work on hip replacement. So the first time is the primary. Any work that's done from there on, if you need to do further work to either fix something or change something, that's revision work. Okay.
What do you have your patients do post-op? So we talked about the pre, like that it wasn't a lot you could do depending on the person.
Okay.
But how do you help them back to recovery? Like, back to daily life. Is it lots of walking? Is it lots of, what exercises do you recommend for a person? What does that recovery look like for a person to get the best out of it?
So the questions for the folks that are following us online is, what do we recommend patients do following their hip replacement to get the best recovery they can get as fast and as good as they can be? You're going to get different answers from different people. And it's not because we're trying to be mysterious, because different people have different views on this. I don't think immediately after the surgery, if you give people some exercises to work on, and they're in pretty good shape, and you have them walk on a regular basis, most people will do really well, okay? If I'm concerned, I'll have people do therapy afterwards, but usually I'll have people come in after hip replacement. I want to see how they're doing in 2 weeks. If they're walking extended differences, they're doing their exercises, they look really pretty good, I'll let them do a lot of their therapy, and then as time comes, I'll get them involved with a therapist. A lot of folks have a certain number of therapy visits they can do in their plans. I don't want to do them right away. I want to push them afterwards if we need to. But a fair number of people, if you show them the exercises, they will get back to really high level of functioning on their own, and you really got to individualize that. I mean, I think that's a tough blanket statement, but I've had some people that were really fantastic candidates, and they said, look, I want to push the limits of this. The one cyclist that I had that looked like competes, she was sending me her times 3 weeks out from surgery, and she had trainers working with her. And that's what was important to her, so you work with that, and that's where she wanted to get to. But I think the key is the right amount of therapy when for the right person. And talk about that with your doc. Say, these are my goals, this is where you want to go.
Yeah, I totally agree with what John said. It's very individual, and so for you, for example, you're young, you're healthy, you're in good shape. If you were to get a hip replacement, my biggest concern for you is that you would go back to too much too quickly, right? And you'd have the mind. I'd be worried that you would have the mindset, okay, now I'm fixed. I've got to get on this thing to get better as fast as possible. And that's a good mindset to have, but just not in tomorrow, and not just give it a few weeks, let the soft tissues heal, let the inflammation from this trauma of surgery go down, and then you'll have time to build that back up. I honestly wouldn't worry about it. You'll end up getting to a very functional state, probably faster than you think you'll be able to. And I've found in young people with these minimally invasive approaches that sometimes they're their own worst enemy because they're so motivated to get going early on, and they take a big step forward and they end up taking 2 or 3 steps back because of it. So I kind of rein people in. The young, healthy people that get these first couple weeks, I try and just have them do the gentle strengthening exercises that the therapist taught them in the hospital, just walking with some assistance, maybe a cane, and then kind of ease back into it. And just be grateful that they don't have the severe pain anymore and they're not needing Percocet and hydrocodone to sleep,
There's a certain time course to this. The parts we use for most hip replacements nowadays, years ago, the first modern hip replacements were done late 60s, and we cemented the parts in. And that was the way it was done for years. In the 90s, around 2000, we cemented some of the parts, but we used other parts that the bone would grow onto. Nowadays, we use almost exclusively for hip replacements parts that the bone will grow onto. What Ben was getting at is you can be too motivated. This is relying on your body's ability to heal the parts with your bone. So for example, if you break your arm and you're really motivated and the doc puts you in a cast, say, I want this to be healed next week. That's not how Mother Nature works. Same with these parts. Your bone will heal onto them. It starts to get some bone on growth, 3 weeks, 4 weeks, getting kind of solid, 6 weeks, gets really strong by 12. But you have to let Mother Nature kind of do their thing. There's certain things you can't accelerate. It just means, like, if you enjoy mowing your lawn, you got a great mower, you want to mow it every day. No, grass grows at a certain speed, bone heals at a certain speed. Don't make yourself miserable in the process. There's a little bit of just sort of, okay, go along with it, do what your body's ready for, and we sort of guide you through it.
Another question regarding the timing of 2 surgeries, and the question is, would it be possible to have hip replacement and be back to work in as little as 8 weeks? I'll start on this. The question is timing between the work and the hip replacement. Again, this is in the same line what John and Ben mentioned. Everybody is different. If you have a very active lifestyle, you're young, active, you can be back to work within 2 to 3 weeks, 4 weeks. It depends, in my practice, how active the person is before the surgery. If somebody is bedridden, wheelchair bound, no, they're not gonna do that shorter rehab. Young active patients, good muscle tone, not high BMI, they can be back in 3 to 6 weeks, depending upon their motivation and pain perception.
And I would just add to that, the other half of it is, what do you do for a living? If you've got an easier job like me sometimes in clinic, I just get to sit and visit with people, yeah, that's pretty easy. If you're a construction worker, a lumberjack, or you're in roller derby, you're probably not going to be doing that in a week or two. So it's tailoring it, what do you got to get back to doing? I mean, it's harder if you're spending all day and your job's on, cement floors in a factory. That's harder than sitting and answering a phone.
And the question was, our person, she teaches at school. Ben, any comment about the teaching and return to work?
Yeah, so I had a woman who had a knee replacement who was in charge of a daycare, preschool age kids, and she went back at 4 weeks, 3 or 4 weeks to doing that. And I was impressed. I didn't think she would get back that fast, honestly. Chasing little preschoolers around, I thought it would take her longer than that. But she figured out a way where she could sit most of the day and kind of do most of it from a chair. It really depends on how much you got to be on your feet and how much you have to be moving. So,
And I have one patient who was back to her managing own daycare within a week. So it just depends on motivation, pain perception. We do the same surgery on everybody, and that determines. Another question, the question for all three of us, and maybe Greg can help. How do we see the patient? Does one need a referral to see one of the surgeons for consultation? Yes, we have a phone room, or you can check with our folks to make an appointment with any of us. We have a same comprehensive team approach. Question about referral for consultation.
To be perfectly honest, I'm sort of the new guy on the block, learning how all this. I presume we have a very catchy phone number, 882 bone. Okay, I know that's embarrassing. I don't know
Greg,
the mainline phone number in.
Greg, can you put that on the comment, the number to call
Can
for
you do
the
that?
consultation?
Yeah. Sorry, that's fantastic. Sorry, you've got 3 doctors here who are not social media geniuses trying to orchestrate this and make it work. But I think we're not doing that bad.
yeah.
But I think that also depends on how your plan works for you too. Some folks do need referrals, but I know for a lot of folks they just call in and we see them directly. And I don't think we require anything. So we're happy to see you. And even if it's something that, I mean, hey, I've got a great doctor at home. This is what I heard. I just want to have somebody just to go through things. Is this an option for me? Yeah. I have folks of mine, and if I'm ever asked to, do I care if a patient might see somebody for a second opinion? Absolutely not. I mean, you'll get different opinions. And someone who's comfortable in their work, has been doing this a while and thinks they do good work, really doesn't have problems with someone else taking a look and telling what they think either. I think that's a good thing. I mean, if I was a patient and someone's going to tell me, you're going to have a major surgery on your hip or knee or it's going to lay you up, I'd want to know what more than one person who does this think. I would. And if a patient of mine asks if they want to see someone else, I wouldn't take it personally. I think that's probably pretty wise.
Yeah, that's one of the great things about working here at the Missouri Orthopedic Institute. I found that in patients where I didn't think that they needed a hip or a knee replacement from me, that wasn't the best thing for them, I've oftentimes been able to get them in to see one of my partners, either with the spine team or with the sports medicine team, the same day even. I've been able to get them, walk them down the hall and they don't have to come back. They don't have to make a separate appointment. And so a lot of the times in other places, you have to go home and wait another week or two. And so it's been really nice, especially in people that have to travel a long distance. Obviously, it doesn't work out that way all of the time, but I've been pleasantly surprised that it seems to work out a lot of the time that way. So,
one comment, a lot of these discussions we are doing about the primary or first-time hip replacement, which we all three or all our partners feel this is the straightforward, easiest operation we do. We get a lot of referrals for revision or redo, and that's where we have much more experience how to handle those problems.
So,
Okay.
so I think, thanks to everybody for coming out. Appreciate it. Hopefully got some good information out there. And thanks to everybody watching and following us on Facebook. So with that, we'll sign off. Thank you.
Thank you, audience here and on the Facebook. And Greg can post the contact number for all three of us if somebody wants to reach through either email or questions. Thank you, everybody. Bye-bye.